Good afternoon, everyone. This is Dan Marsala, and this is my Week 5 presentation on what ABGs can tell us about changes in work of breathing. So in this PowerPoint, we're going to cover a couple things. So as an RT, you're going to see patients present with different levels of increased or decreased work of breathing. And in this presentation, we'll discuss how ABGs can give us an idea of what's going on behind the cause of patients' change in work of breathing. And we're going to cover a couple examples of respiratory and metabolic acidosis and how that can affect changes in breathing, work of breathing for patient. So what is an ABG? An ABG is a test that measures the pH, oxygen, and carbon dioxide levels in arterial blood, and also actually measures your bicarbonate levels as well, which is released from your kidneys. It's used to check the function of a patient's lungs and how well they're able to move oxygen into the blood and remove carbon dioxide. And they're commonly used in the ICU and the ER setting, but they can be drawn on any patient on any floor at any time, as many of you know. So reasons why you might draw an ABG: shock, trauma, uncontrolled diabetes, asthma, COPD, drug overdose, metabolic disease, chemical poisoning, and we draw them to see if the treatments to reverse these conditions are actually working. So you have some key components of an ABG. You have your pH, your PaO2, which is your pressure of arterial oxygen, PaCO2, which is, again, your pressure of carbon dioxide in your blood. You have your HCO3, which is your blood bicarbonate levels, and your O2 saturation. So your normal levels, so pH, 7.35 to 7.45. In a perfect world, a perfect blood pH would be 7.40. Your PaO2 is 80 to 100 millimeters of mercury. Your PaCO2 is 35 to 45 millimeters of mercury. Your bicarb is 22 to 26 MEQL, and your O2 saturation is 94 to 100%. So how do we interpret an ABG? So there's a whole bunch of, I guess you could say, different mechanisms that an ABG can, or what could be the causation that an ABG will tell you. So your first one is your respiratory acidosis. So in a respiratory acidosis, your pH is going to be down, so that means below 7.4. That means your blood's becoming more acidic. Your CO2 levels will be up, and your bicarbonate levels will be normal. In a respiratory alkalosis, your pH is going to be up, which means it's going to be more alkaline, so it's going to be above 7.40. Your CO2 levels will be down, and your bicarbonate levels will be normal. So in a compensated respiratory acidosis, your pH is going to be down. It's going to be in that, below 7.40. Your carbon dioxide levels are going to be up, but you're also going to see your bicarbonate levels are up. So your bicarbonate levels are going to increase to help kind of try to counterbalance that CO2 and that acidity in the blood. So a compensated respiratory alkalosis, your pH is going to be up over 7.40. Your CO2 levels will be down, and you're going to also see your bicarb levels drop. Again, as your bicarb levels fall below that 22 threshold, that's in order to try to make the blood more acidic to restore that pH balance. So next, you have what's called a metabolic acidosis. In this, your pH is going to be down, your CO2 levels are going to be normal, and then your bicarb levels are going to be down. In a metabolic alkalosis, your pH will be up, your CO2 will be normal, and your bicarb levels will be elevated. So in a compensated metabolic acidosis, your pH will be down, your CO2 is going to be down, and your bicarbonate levels are going to be down. So when a person's trying to compensate for metabolic acidosis, they're going to be huffing and puffing and trying to blow off that CO2 to counterbalance the low levels of bicarb. And a compensated metabolic alkalosis, your pH will be up, your CO2 will be up, and your bicarb will be up. So in this case, respiratory rate's going to slow down, and that's going to help try to raise that CO2 level to counterbalance that increased bicarb level. And then you have what's called a mixed acidosis. So in this case, your pH is going to be down, your CO2 levels are going to be elevated, and your bicarb levels are going to be down. So in this case, both your CO2 and your bicarb levels are causing the acidosis. And then you have a mixed alkalosis, which will be your pH is up, your CO2 down, and your bicarb is up. So again, you have both a respiratory and metabolic component that is causing the alkalosis. So one example where you're going to see increased work of breathing is your COPD exacerbations. This is one of the most common ones as a respiratory therapist that you're going to see. So how will a patient present with a COPD exacerbation? They could have increased coughing, wheezing, shortness of breath, change in color, thickness, and amount of mucus, severe shortness of breath. So in these patients, you might see them having accessory muscle use, tripoding, pursed lip breathing. In the cases of hypoxemia, you're going to have cyanosis if it's severe. You could see confusion, disorientation, difficulty speaking in full sentences. And in severe cases, you might have somnolence. So in cases where CO2 levels keep rising and are extremely high, patient might start becoming hard to arouse, might only be arousable briefly with like painful stimulation, like sternal rub, that kind of thing. So what can we see on a ABG with COPD exacerbation? So you're gonna have, a lot of COPD patients have a mild level of hypoxemia as it is, but in cases of an exacerbation, you're gonna have worsening levels of hypoxemia. So mild hypoxemia is characterized as 60 to 79 millimeters of mercury. Moderate is 40 to 59, and severe is less than 40. So hypercapnia, this is going to develop as the FEV1 falls below 1 liter a second, or 30% of predicted value. So these patients, they're huffing and puffing, and no matter what they're doing, they're just not getting rid of that CO2. So as this happens, obviously those CO2 levels are going to increase. So anything above that 45 threshold is where you're going to start to be concerned about their CO2 levels. Your pH below 7.3 indicates acute respiratory compromise, and your bicarb levels. So in some patients that are chronic COPDers, you're going to see elevated bicarb level because they live with chronic hypercapnia. So this is going to be to compensate that chronic hypercapnia. So in some of these patients, you might do an ABG and it could be, 7.25 with a CO2 of 80 and their bicarb's like 33. In those kind of patients, they probably actually live higher than, that 7.45. They might live with a CO2 in the 50s, which explains that bicarb level being in the 30s. So these patients, if they present tripoding, working to breathe, what they're trying to do is that is the body's trying to maintain homeostasis. So they are trying to blow off that CO2 that's accumulating and building in their blood. So in these patients, you might need to start them on something like BiPAP. And in the severe cases where airway compromise is a concern because, they're somnolent and can't wake up, that, obviously requires intubation. So diabetic ketoacidosis, this is a really good example of a metabolic cause for increased work of breathing. That is something that you might see often. So in diabetic ketoacidosis, they present with polyuria, polydipsia, vomiting, dehydration, altered mental state, including coma, and Kussmaul respiration. So that is like this heavy hyperventilation, taking really huge, deep breaths, okay? So in DKA, what are you going to see as far as your ABG results go? So that's going to be a pH of 7.25 to 7.3. In severe cases, it can be even lower than that, below 7.0. A bicarb of 15 to 18, and in severe cases, below 10. And a PaCO2 of less than 35. So in these cases, patients with severe DKA, they're going to come in and you're going to walk into that room because they're going to call you down, probably because they're thinking it's a severe emergency, which in a lot of cases it can be. And they're going to be, chugging along, that Kussmaul respiration, that hyperventilation, taking these huge deep breaths. And this is going to explain it because that bicarb is low. So it's causing metabolic acidosis. So they're going to be working to try to blow off even more CO2 to get that blood pH normalized and maintain homeostasis. Actually, I just recently had a patient that presented with DKA, ABG. It was reading below 7 for a pH. Bicarb was in the low teens. Their CO2 was in the 20s. Patient was actually alert, conscious, talking, surprisingly. They asked me to put the patient on BiPAP just to kind of help with his with their work of breathing. But it was, this patient was breathing at a respiratory rate in the 30s with no leak. They were pulling almost 2,000 for a tidal volume, and their minute ventilation was like 60 liters a minute. So in these cases of DKA, what you need to correct is that bicarb level. Also, you need to get their blood sugar under control, get that return to a normal level, and then you need to get that bicarb return to a normal level. So in these patients, you'll see them put them on a bicarb drip to help improve that. And once you get that bicarb under control, then you will, get that work of breathing back under control as well. So questions, why would a patient with a metabolic acidosis present with an increased respiratory rate and depth? And in a COPD exacerbation, why would a patient become somnolent? Here are my references. Sorry, I went over about a minute and a half, and I just want to thank you for looking at my presentation.